Okay. Sorry, Sahand. We are definitely having some technical difficulties, but I want to welcome everyone to our third session in the Summer Equity, Diversity, and Inclusion Summer Series. I am pleased to introduce today Dr. Rahnama, as he is indeed an internist who we happen to share with dermatology. Is that right? I think that's right. So let me say that he's a graduate of Northrop High School in Fort Wayne, Indiana, and later graduated medical school from the University of Michigan in Ann Arbor. He is a proud graduate of the University of Texas, San Antonio, where he finished his residency in both internal medicine and dermatology. Since joining IU nearly 6 years ago, he was the director of inpatient dermatology consults at Methodist Hospital, has spearheaded efforts in teledermatology, and sees complex medical dermatology in his clinics. He's the dermatology department's lead in diversity, equity, and inclusion, and I hear that he's honored to give a talk about this subject. Welcome, Dr. Rahnama. I'm so happy to have you here.
Thank you for that kind introduction, Silk. I'm going to begin. So I don't get distracted, I'm just going to turn off my video and we will focus on the presentation. I want to say hello and thank you and welcome to my talk, Hidden in Plain Sight, Diagnosing Brown and Black Skin, Dermatologic Misdiagnosis in Skin of Color. You heard my name is Sahand Rahnama, and I'm an assistant professor of dermatology and internal medicine at Indiana University School of Medicine. Thank you so much for inviting me here. As for my disclosures, I will not discuss off-label usage of products nor endorsements. I have no financial disclosures. My only disclosure is that I'm a millennial, and thus I will use some memes to get some points across. So forgive me for that. I do want to express my gratitude, first of all, to the most important people who are our patients. And my patients in particular that I saw, some of them allowed me to use their photos for skin of color presentation. As any medical educator will tell you, our efforts wouldn't be possible without the help and participation of our patients. As much as I can, I've tried to protect their identity, and that's been very important to me. So if you wanted to see more details of these photos beyond this presentation, many of these diseases, their photos are available on the public domain. So you can find some further images there. I'm also happy to share them in private. They're just a Google search away. I also wanted to introduce who I am and why I'm giving this talk and why it's so important to me. First, I'm a dermatologist. In other words, I'm a doctor who tries to help patients with their skin disease as part of my job. And these are diseases that I see on a regular basis. I'm an American of Iranian descent. And to me, that's positioned me at a vantage point that in some ways is like an outsider looking in at American culture, while also, on the other hand, being very much a part of the culture. I'm a Hoosier. I grew up in Fort Wayne, Indiana, and to me, the needs of the state and the people who live here, it's personal for me in that my patients could easily be my friends and neighbors. And ultimately, I'm a concerned citizen. Part of why I want to help is because this is the right thing to do, to help alleviate a large amount of suffering related to disease. There's a lot to cover. We can't cover everything. I'm going to pick and choose to focus on some areas that I think are a microcosm of this giant topic. So today I will speak about a few conditions that are common and misdiagnosed in skin of color. I will also speak about a common condition that occurs in skin of color and that needs a diagnosis before it is too late. And I want to end positively and discuss why the future holds the promise of better days as we discuss skin of color. First, as a physician, I wanted to show one of my favorite paintings from the artist Bruegel. This is a pastoral scene titled The Fall of Icarus. As we take it in and we see the world going about their business in this scene, I want to later come back to it and explain why it's so important to us as physicians and the symbolism that it contains. So first, what do we do when something is diagnosed as acne, but it's not acne? Hopefully I've piqued your interest. This is one of my patients. She was diagnosed with acne in her late 60s. That would be very atypical. Over-the-counter acne treatments led to burning and they didn't help. So she wanted a second opinion. I would draw your attention to the central facial redness, the lack of blackheads, and the red pustules. So she, in fact, did not have acne. Instead, she had a condition called rosacea that is commonly misdiagnosed as acne for all people, and we will learn that it is more misdiagnosed in skin of color. Rosacea is composed of redness disproportionate to how many papules and pustules there are. It is usually associated with facial flushing, eye irritation, no blackheads, and is mostly located at the center of the face. Contrast that to acne, where the redness is mainly concentrated around papules, where patients are more likely to tolerate over-the-counter acne products. In acne, there's no flushing, there's no eye symptoms. Acne has blackheads, and often the lesions are located outside the central face, such as at the jawline, the chest, the back, and the shoulders. This is another one of my patients with skin of color who was misdiagnosed as having acne. Note he has the central facial redness without any blackheads, and in this case, only a few red papules. This is another patient of mine who was misdiagnosed as having acne who wound up having rosacea. She has central facial redness and a few papules. She did also have intense flushing and intolerance to the over-the-counter products, similar to what we had described. And she had this going on for a few years, seeing medical doctors actively before receiving the correct diagnosis that resulted in the help that she needed. These patients that I'm showing are typical. They are not the result of me cherry-picking rare cases. And a rosacea diagnosis is usually clinical, meaning that we need someone who has seen this disease in clinic to make a diagnosis. There's no good blood test and usually no need to biopsy someone's face to tell the difference between acne and rosacea. So a biopsy also isn't of any help practically. In other words, if a doctor said they needed to either take your blood or take a skin biopsy to tell you you have acne, you should run from that doctor. So having seen so many cases of rosacea in Black skin, in Latin skin, in Indian skin, in Middle Eastern skin, I've come to the conclusion that rosacea is underdiagnosed of skin of color. Well, why is that? Why have we come to this point where rosacea in skin of color is so under and misdiagnosed for such a common condition? It's probably because we are resting on faulty teachings from the past. This passage is from a popular dermatology reference site that's used by the public and physicians, but it's typical for its teachings on rosacea. And I'll note, although rosacea can affect anyone, it is more common in those with fair skin, blue eyes, and those of Celtic or Northern European descent. It may be more difficult and under-recognized in patients with skin of color. This is a teaching that you'll actually find in textbooks, and it's taught in teaching institutions throughout the country. For physicians, including dermatologists, it's the predominant view of rosacea. Even though the above passage allows for the possibility that rosacea may be underdiagnosed, in practice, this paradigm from the past, and still to this day, is that rosacea is a disease of patients who primarily identify as having European descent. And this paradigm impacts research, and those flawed research findings can be transmitted to a new generation. In this example from the National Rosacea Society, no less, a survey of self-identified rosacea patients, the research concludes that rosacea runs in the family of patients and primarily those of European ancestry. And they conclude it is less often seen in skin of color. But this research is flawed. These patients are self-identified. They already know they have rosacea. And so if these patients if we looked at patients with skin of color, they may not have ever been diagnosed with rosacea in the first place. So they would never self-identify. And so they would not show up in the study. And then therefore they would not demonstrate any family links. As Dwight Schrute would say, this is circular reasoning. The reasoner began with what they are trying to end with. In other words, we started with a group that was already selected as having rosacea. They described that they had rosacea, and then therefore their family members are more likely to also have people with rosacea, and it may not be found in patients with skin of color who were not diagnosed with rosacea in the first place. And it's easy to find several studies similar to this with similar flaws. Here's another one. In this one, the researchers examined the genomes of customers who submitted their genetics to the company 23andMe. And then they limited the analysis specifically to customers of European descent. The researchers next asked them if they had ever been diagnosed with rosacea, and then looked at the genes of the patients with and without rosacea. So in the study design, the genomes of patients with skin of color were excluded. And it's ironic that this news article actually celebrates how the genome-wide analysis is an unbiased modality of genome analysis. But without including patients of color, statistical bias has already been introduced from the very beginning of the study design. This is a different study, even though it looks very similar, and it's by a completely different set of researchers. In this one, they again did a genome-wide analysis of rosacea patients, again from the 23andMe customer database, and again restricted it to patients of European descent. This time, they looked for genes that were related to rosacea severity in this case. Again, patients of color were excluded. And there are many studies like this. In these studies, we're starting off already missing a large portion of patients and not analyzing their genetics or analyzing this disease. And we are missing them from the very beginning based on this original assumption that this is mainly a disease of patients with European ancestry. In other words, a large part of our understanding of this disease is missing because patients are being excluded based on a prior assumption. And this occurs in our research, and it filters down to our teachings. So rosacea in the end becomes like this parable of the blindfolded and the elephant. One blindfolded person feels the tusk of the elephant and thinks they're feeling a snake. Another one, the flank, and thinks they're feeling a wall. Another one, the tail, and they think they're feeling a rope. They're only sensing a part of the larger whole and missing the point. Missing the point is exactly what we are doing when we examine rosacea and limit the studies based on faulty presumptions on who can get it. We're missing a full understanding of the disease by excluding skin of color patients in our studies. And again, these studies will eventually trickle down to our thoughts about the disease as we teach them in the teaching institutions. And these teachings are then passed on through the generations. And it's not just me. Recently, experts in skin of color are making this point more forcefully in print and in studies, that rosacea is underdiagnosed, that the condition is suboptimally made as rare in skin of color, when in fact it may not be. And this is a real opportunity lost. Treatments are effective in rosacea, and many of them are cheap and generic. The main barrier is actually getting them into the hands of our patients. And for us providers, we may be the rate limiting step. Shifting gears, similar to our prior disease, rosacea, eczema is also a common disease that is often misdiagnosed in skin of color as well. This time, the misdiagnosis is not related to faulty presumptions about who can get it, but based on the morphology of the condition itself and medicine's collective unfamiliarity with diagnosing disease in skin of color. Eczema is one of the most common dermatologic diagnoses, and it can look different based on the skin tone in which it occurs. In skin of color, the scale may be more pronounced and the process may seem more well-defined. Contrast that to the picture on the right. In fair skin, it is poorly defined and it has less scale. And when it is more well-defined and has more scale, it is more likely to be misdiagnosed as psoriasis. Again, on the left, this is eczema and skin of color, while the image on the right is psoriasis and fair skin. For the physician or provider who is diagnosing it, it does take some degree of experience diagnosing skin of color, or ideally training with someone who has seen these conditions present in skin of color in order to contrast and make an accurate diagnosis. This is another example of eczema and skin of color, showing more follicular prominence and being more well-defined in the eczema and fair skin. To make this point, again, eczema is a clinical diagnosis. And so it is best diagnosed by someone in a clinic, and that someone needs to have some experience learning about what eczema looks like in skin of color. A biopsy is only of partial value. These biopsies can be nonspecific, and they're usually most helpful to rule out other conditions that can mimic rosacea, like psoriasis, lichen planus, drug reactions, or urticaria. Blood testing is not helpful as it cannot diagnose this disease. So like rosacea, this is a common disease, but the main way to diagnose it is in the clinic with someone who has learned to recognize this disease. Without that knowledge, the unaware physician will just have the correct diagnosis slip through their hands. And that's a shame because eczema is imminently treatable. We can first start simply with gentle skincare recommendations and topical steroids like hydrocortisone or triamcinolone. Immunosuppressive agents and phototherapy have been traditionally used for severe eczema, and now there are new exciting targeted treatments that have recently hit the market. And the precise treatment is therefore the practical result of making a correct diagnosis. These new effective therapies, they're targeted against the specific disease, and they won't work against others. So in other words, new highly active treatments specifically for eczema have no impact on psoriasis if we make a misdiagnosis. And vice versa is true, that new psoriasis treatments that are specific against psoriasis will not be active against eczema. And eczema is important to treat because treating eczema is crucial because eczema itself dramatically reduces quality of life. Not only does the itching, blistering, and sores cause suffering, but also the manifestations of eczema lead to separation of patients from the people around them. And that further decreases quality of life. And eczema will then have a ripple effect on the caregivers of patients with eczema. And these caregivers will suffer from a disruption of family time, loss of sleep for the patient and caregiver, anxiety and depression, financial worries, decreased work productivity. So it's not just a simple skin disease. Excuse me. Children with eczema will see this manifest also in their school. The itching and rash and the social emotional issues have been shown in several studies to correlate with poor performance in school and social isolation. And this is magnified in skin of color because while eczema has strong impacts on all patients, some studies suggest that for patients with skin of color, this damage can be more severe. In this study, Black children with eczema were more likely to have severe eczema, but less likely to receive medical care. Those that did not seek care may have had more severe disease, in fact. Those that did seek care actually may have had more severe disease, excuse me. In this separate study, Black and Latino children with eczema were more likely to miss school due to severe eczema compared to the non-Black Latino children. So for these conditions, for these children, not diagnosing this condition leads to severe consequences, can lead to severe disease, and can impact life outside of the skin. So this highlights why it's so important to make the correct diagnosis in the first place. Again, shifting gears, hair loss is another condition that is often misdiagnosed in skin of color and has an outsized impact on quality of life. This painting is entitled Hair Loss, and I think it captures the emotions, specifically sadness and resignation, that are felt by many people when losing hair. Hair loss is an incredibly emotional topic for all people. This passage comes from Gabriel Garcia Marquez's Love in the Time of Cholera, and it captures the mood as accurately as anything that I've ever read regarding hair loss. Until that time, his greatest battle, fought tooth and nail, and lost without glory was against baldness. From the moment he saw the first hairs tangled in his comb, he knew he was condemned to a hell whose torments cannot be imagined by those who do not suffer them. He struggled for years. There was not a pomade or lotion he did not try, a belief he did not accept, a sacrifice he did not endure, in order to defend every inch of his head against the ravages of that devastation. This quote by poet Maya Angelou is one that I hear commonly from many of my patients. A woman's hair is her glory. It shows the attachment to the hair and how hair is exalted as a treasure. My patients say these exact words to tell me how important their hair is to their identity. In fact, I hear this quote so much, I thought this quote had come from Maya Angelou, but in preparing for this, the earliest reference to this may be from the Bible, 1 Corinthians. But if a woman have long hair, it is a glory to her, for her hair is given her for a covering. When treating hair loss, the number one rule is that it's easier to keep hair rather than try to grow new hair to replace hair. We therefore must accurately detect and identify the type of hair loss for best treatment. And that's the most important thing from the beginning. Hair loss itself is a big subject. We're only going to scratch the surface. It's enough for a full series of talks specifically on that subject. But for our purposes, I just want to give a quick breakdown of hair loss before we focus on one type specifically. So the first type is pattern alopecia. Androgenic alopecia is another name. It's the most common. It is age and hormone related, and treatment is based on manipulating hormones to try to keep the hair that is there present and keep it there. Alopecia areata is autoimmune related. The immune system is attacking the hair in the scalp usually, can be in other areas on the body rarely. The treatment is based on altering the immune system and its attack on the hair. This is an important condition to identify, especially now because there are some new exciting treatments that have been brought to market to treat this. But the condition that I want to focus on, because it's so important to identify early, is scarring alopecia, in one subtype specifically. In these conditions, something causes the hair follicle to be destroyed. And when it is destroyed, it's replaced with scar tissue. In these conditions, when hair is lost, then no other treatment other than transplant can get that hair back. I want to focus on a condition named centrifugal cicatricial alopecia, or CCCA for short. Central meaning the center of the scalp. Centrifugal means it spreads out from the center. Cicatricial is another word for scarring, and alopecia means hair loss. This is the most frequent cause of scarring hair loss in African American women, as noted by the American Academy of Dermatology. As in this example, there's scarring in the center of the scalp. If you look with a microscope, there are no hair shafts present in the center of the scalp, while the hairs outside of the scarred area are normal and thick. This is CCCA, and at this stage, no medical therapy can bring back the hairs that were lost. And the problem is that you need some training to identify it, because pattern or hormonal hair loss, specifically in women, often starts in the center of the scalp with thinning. So CCCA is on the left photo, pattern alopecia is present on the right photo. And since both start in the center, it does take some degree of expertise to make an accurate diagnosis to decide upon how to treat. This is one of my patients. She had hair loss that had been going on for 10 years before we saw her at Indiana University. She had been seen by other doctors, including a couple of dermatologists, before she had seen us, and she had been misdiagnosed during this time. At this point, while we had given her an accurate diagnosis of CCCA, unfortunately, there was no treatment that we could recommend other than hair transplant to try to get her hair back. So this diagnosis, similar to rosacea and eczema, is that for the most part, CCCA is a clinical diagnosis. You need someone who has seen it before we can make it. The biopsy is not always helpful because the biopsy first can be painful to obtain on the scalp, and many times it can be nonspecific. So while many times it can be nonspecific, each and every time we obtain a biopsy, that biopsy needs a clinical assessment to support its findings. And as internists, we're used to applying a pre-test probability to our tests, and it needs to be done for biopsies as well. When we first diagnose CCCA, if we are early, we can use some treatments to try to slow down the progression and see if we can catch it. But if it is widespread, we have to then look at transplant to try to restore the hair. The treatments of CCCA are not easy. We can do some treatments early by injecting some steroids into the scalp to reduce some inflammation. We can use immunosuppression to reduce some inflammation as well. After that, other than hair transplant, we're stuck. There are no FDA trials at the moment for treatments that could be on the horizon for this condition. CCCA has an interesting history. It was originally thought to be related to traumatic hair care practices. In the most influential early description of CCCA, it was coined as hot comb alopecia, with the authors asserting the cause is unmistakable, namely the practice of straightening the hair with a hot comb. And this term of hot comb alopecia occasionally is still in textbooks and is heard by many of my patients. And sometimes they're in tears, blaming themselves for the use of a hot comb hair straightener. And this has become the dominant theory that CCCA was originally thought to be solely related to traumatic hair care practices. And thus it was given this name, hot comb alopecia. Interestingly, it was given this name by a team that did not compose anyone that had skin of color. Another theory then became that it was related also to chemical relaxers and perms. So I remember as a student, and we have students in residence, we ask these histories about these hot combs and chemical perms and relaxers. We asked them ad nauseum. But some very astute researchers noted that this condition was passed down in families and would be passed down from one generation to another very clearly in a process called autosomal dominant transmission. And so some researchers that noted this condition had this autosomal dominant spread, they actually thought about, could there be a genetic component? In this article published in 2018 in the New England Journal of Medicine, the researchers investigated the genomes of the patients with this condition. And when they investigated it, they noticed a large portion of these patients had a genetic variant in a gene related to hair shaft development. This article made it to the New England Journal because it completely changed the paradigm of this disease. No longer could we think of this disease as solely related to the use of hot comb. There's something here that explains a predisposition, a genetic basis, and a mechanism for this condition. It allows us to think of this condition in a more helpful way rather than blame the hair care practices solely. I also wanted to point out this was a group of multinational and multiracial researchers who came up with this finding. And to me, this article actually changed my paradigm, the way I think about this disease and how I counsel my patients. First, I tell my patients they did not do anything wrong or abnormal to cause this. It is truly more related to the fault in our stars than the fault in ourselves, in other words. It also informs our patients that they have a susceptibility that all potentially traumatic hair care practices should be avoided. So specifically, as we're trying to prevent this disease in the dermatology clinic, we often ask our patients to wear their hair naturally in styles that are not painful. The genetic basis of this disease and elucidating that is helpful to educate and warn family members about this predisposition so that others can be warned and spared from future hair loss. And for me, finding an actual basis of this is helpful because it gives me hope for the future. For nearly 50 years, we were stuck thinking of this condition as simply hot comb alopecia, as blaming it on a specific hair care practice. Instead, rather than targeting hot comb alopecia, this paper gives us a new target, a genetic basis, a protein, something that we can act upon. And that gives me hope that more research on this condition will lead to better solutions. And I think in the grand scheme of things, with things changing, I think there's more hope on the horizon. As we saw in the past conditions, discoveries are being made and attention is being paid to dermatology with respect to skin of color. Our times are changing. Some of these changes came from increased scrutiny, as shown in this New York Times headline in 2020, dermatology has a problem with skin color. This article highlighted the fact that doctors are trained to learn disease on fair skin and had a harder time in clinic and in didactic teachings diagnosing skin of color correctly. So with this increased scrutiny, the dermatology community all had a bright idea at once. We need to make some changes. In 2022, the American Academy of Dermatology added a skin of color curriculum to its website. They offer 5 courses that are on demand for students, residents, and practicing dermatologists to learn about common conditions in adults and children with skin of color, to identify and prevent complications that may occur in patients of skin of color during surgeries or procedures, and to better treat conditions that occur in skin of color. Excuse me. Social media accounts on Instagram also drew popular attention and also drew physician followers through accounts like Brown Skin Matters. These accounts allow interested learners to see and recognize disease as they occur in skin of color. Seeing these diseases in skin of color should help improve familiarity with their presentation and therefore help make the diagnosis. Additionally, companies used to help decision support in medicine at the point of care, like Visual DX, have added skin of color features. This organization, Visual DX, they have an app and a website, and you can use their product to help view images of disease and then review a generated differential diagnosis. Now in their application, and it's functional today, you could use it today, you can sort and view the images in different skin types, including specifically in skin of color if you wanted to. So the bottom line is that, in short, our trainees now expect to be taught the nuances of skin of color. Institutions and companies are supporting education about skin of color. And most importantly, our patients are expecting more from the medical community. So back to Bruegel. Why is this picture a favorite of mine as a physician? Well, because in this scene entitled The Fall of Icarus, the patient shows a tragedy off in a small corner. Well, everyone in the scene is oblivious. Perhaps this would be preventable if someone paid attention. I think the artist is making a comment on all of us, that there's human suffering happening around us, and if only we would pay attention to it. And maybe if we paid attention to it, maybe we could fix it if we noticed it. So I believe that more attention to recognizing diseases that occur in skin of color and how to diagnose them will help bring advances in education, research, and treatment that will help alleviate the burden of these diseases on our patients. Art like this image is timeless, and it communicates a message to us that's as vital today as it was in the 1500s when it was made. And I think for us, this is part of what our task is to help recognize these diseases in skin of color and do a better job at it. As we finish, and we've reached the end now, my hope is that we see this issue isn't a partisan issue, it's not a niche issue, but that it is a human issue that all doctors and healthcare providers should be interested in. As the Persian poet Sa'di once wrote, Human beings are members of a whole, in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. Thank you for your time. I also wanted to give a special thanks to Dr. Silk Soto for her friendship and her mentorship, and for her encouraging me to give this presentation. With that, I'm going to turn on my video and open it up to if there's any questions.
Thank you very much, Sahand. Can you hear me okay?
Yes.
I think my technical issues have been resolved, but we'll see how it goes. There is indeed a couple of comments in the Q&A, and I want to encourage everyone to submit your questions so we have a little bit of time here so we can have a rich discussion. Dr. Aronoff, if it's okay, I just said your name, so he says, thank you for this excellent talk. I might add that the involvement of Dr. Albert Kligman in the work on CCA, or what he called hot comb alopecia, is notable. He was a notorious exploiter of persons of colors and incarcerated people, as documented in the excellent 1998 book, Acres of Skin by Alan Hornblum, which is well worth the read. I love that Dr. Aronoff always has a book suggestion for us.
Dr. Soto, maybe share that book title with me. I would love to read it. Dr. Kligman does have has had a very strong impact on dermatology, not always for the positive, and he's really a notorious figure. I'd love to read that. Thank you, Dr. Aronoff.
Yeah, I just put it in the chat for everyone. We have another individual who's saying, this was awesome. Thank you for this. And I concur.
That's so sweet of you. Thank you.
Yeah, that was awesome. I learned a lot. And, you know, one of the things that I had noticed, and we try to coordinate to do after this session, was we actually have, there's actually a medical student that is working on a lot of images, and you can follow him on Instagram, where he has actually focused a lot of his work on Black and brown skin, and I will add it to the chat if I can follow, if I can find his link. It's definitely really interesting. What else do you think we can do in regards to medical education, especially talking about this topic?
I think this kind of trickles down, and this is something that I think starts with an attitude that this is an easy way to improve the health of the state of Indiana, is that these are conditions that are common, and if we start to look for them, then we can make an accurate diagnosis. And it's kind of interesting, like people can spend a lot of time trying to learn very rare diseases, and they focus on these rare diseases, sometimes I would argue too much. But if you look at skin of color in the state of Indiana, I think it's about 30% of people identify as having a background that would qualify them as skin of color. We're missing that large portion. So I think, first of all, what we're doing in the Department of Dermatology is, first of all, we're trying to improve our clinical teaching with the students that we have in the clinic. And then we're trying to work on our didactic teaching for our preclinical students. And I think, and a point I wanted to impress during the talk is that I think sometimes we have to erase what we think we have learned, that we think that some of these diseases like rosacea, for example, we think they may only occur in patients who identify as having European descent. And something that I didn't get to say, this is kind of more of, you know, I don't have a study, it's kind of more common sense, is that a quote I heard that I thought was interesting was from Isabel Wilkerson. She said, color is a fact, but race is a social construct. And that's really important to recognize in the United States, is that if you do some genetic studies, someone who we identify as Black, for example, you know, they may have ancestry with genes more than 50% that are European. So these conditions can easily present in someone who is Black, regardless of what they identify as or what you identify them as. And so some of that education around recognizing it and kind of understanding that race is a social construct, I think would eliminate some of those blinders.
Thank you for that. I wonder also from the side of your other colleagues, right? For example, internal medicine, are there other things that come up that we might be missing in some aspects when we're seeing these patients?
I think there's, dermatology is interesting because some aspects of it can be very different from each other. I think I wanted to highlight these three specific areas because they're very common diseases that I see, and we want to see them early so that we can alleviate the suffering. And those are clinics that would present in the clinic. But one condition, and I almost thought about giving the whole presentation on this, and this is kind of my pet condition, is called hidradenitis suppurativa. It's a condition that we see disproportionately, I would argue, in the state of Indiana compared to other states. When I was actually in medical school, I didn't learn anything about it. And that's not because I was a bad student. Maybe I was a bad student, but that wasn't the reason I didn't learn about it. It wasn't even in a textbook, a review book. And we see it very commonly here at Indiana University. And it was understudied, it's underdiagnosed, it occurs more in skin of color, and it seems to occur more in patients who are economically disadvantaged. So you can imagine that there's a lot of gaps surrounding all these identities, the intersectionality. So I think recognizing hidradenitis suppurativa would be the one disease on the inpatient side that I would recommend. It presents with recurring boils and nodules in the intertriginous areas of the groin and the axilla, because we can do a lot to help prevent progression once it's acknowledged. So that would be the one I would single out.
Well, thank you very much for that. I don't see any additional questions coming in. And I ask all of mine. Is there anything else that you would like to add to your talk today? Final comments here.
Thank you very much. I feel an internist at heart, so I'm honored to give this presentation, and it's an important subject. And I want to just thank you, Dr. Soto. And thank you for inviting me to talk today.
Oh, there's a question about, can you please repeat the diagnosis you just stated? Would you like, are you able to write it in the chat too?
Yeah, I'm happy to. It's called hidradenitis suppurativa, and I will spell it out. It's very interesting, easy for me to say, but I find it very interesting. We're trying to do some research on it currently. If anyone has any interest, please reach out to me. I'm sure there's a lot there that we can explore.
Great. Thank you very much. With that said, I want to apologize, as early on in the presentation, I was having some technical difficulties, and I want to make sure that some of the statements that we're very proud of adding to every single one of the EDI summer series is the acknowledgement that through this presentation and through this activity and summer series, we acknowledge that IUPUI and the School of Medicine stands on the historic homelands of the Miami people, but also displays a vibrant Black community in Indianapolis. I would also like to point out that we do have our final session coming up September 21st, and the title is Using Health Design, Thinking to Create Equitable Workspaces by Dr. Lewis from Thomas Jefferson University, and it's also at the same time 4 to 5. If you can quickly click on the evaluation here, that will be fantastic. We want to make sure that we receive feedback, and we also provide feedback to our speakers about the content that they provided. Lastly, this recording, as well as all the others from this is our third EDI summer series, can be found in our YouTube channel, the Department of Medicine EDI summer series. And I also put the link in the chat for you to follow. I see that Hannah also included the link to register for the next event. With that, I wish everybody a good evening. Again, thank you, Sahand. This was really, really interesting talk, and I thank you for all the effort and information that you put forward to us today.
Thank you, everyone, for your time.
Have a great evening, everybody.
Bye.
Bye.